This is Dr. Julie Schumacher in the Department of Psychiatry and Human Behavior at the University of Mississippi Medical Center. This presentation focuses on obsessive compulsive and related disorders. By the end of this presentation, you should be able to demonstrate knowledge of the signs and symptoms of obsessive compulsive and related disorders, differentiate obsessive compulsive and related disorders from other disorders with overlapping signs and symptoms, and begin to formulate appropriate treatment interventions for obsessive compulsive and related disorders. We will cover the following diagnoses in this presentation: obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania or hair pulling disorder, and excoriation or skin picking disorder. Let's begin with obsessive compulsive disorder. Although the disorder is called obsessive compulsive disorder, and obsessions and compulsions are frequently both present in obsessive compulsive disorder, an individual need only report one or the other to meet diagnostic criteria for obsessive compulsive disorder. In addition to having obsessions and/or compulsions, these symptoms have to be time-consuming, taking an hour or more per day, or cause clinically significant distress or impairment. And as with all disorders in DSM-5, these symptoms cannot be better accounted for by another disorder. But what is an obsession? Obsessions are defined by recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress, and the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, that is, by performing a compulsion. Obsession is one of those words that has different meanings outside of psychiatry. For example, a Katy Perry fan might say, "I'm totally obsessed with Katy Perry right now." Even patients who have other psychiatric disorders might mistakenly refer to their experiences as obsessions. For example, a patient with major depressive disorder and excessive guilt might say, "I'm obsessing about the candy bar I stole when I was 12 years old." In diagnosing obsessive compulsive disorder, it is important to differentiate obsessions from other unwanted and persistent thoughts, such as excessive worry and generalized anxiety, pathological guilt or ruminations in depression, aggressive ruminations such as revenge fantasies after being wronged, paranoid fears in psychotic disorders, flashbacks or intrusive memories in post-traumatic stress disorder, or even realistic fears or concerns, such as someone with memory problems who checks their stove multiple times to make sure they've turned it off. The most commonly reported obsessions in individuals diagnosed with obsessive compulsive disorder are contamination obsessions. This includes fears that one will be contaminated by germs or dirt, or contaminate others. Another commonly reported obsession is pathological doubt. An example of this might be fears that you have lost or don't have things you need, or that you failed to do something important. These doubts are not readily allayed by disconfirmatory information. Importantly, most patients with obsessive compulsive disorder report multiple types of obsessions. Turning our attention now to compulsions, compulsions are defined by repetitive behaviors, for example, hand washing, ordering, checking, or mental acts, for example, praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly, and the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. Like obsessions, it is important to differentiate compulsions that meet criteria for obsessive compulsive disorder and other similar behaviors. Compulsive behaviors are performed to prevent something terrible from happening or escape aversive situations. In contrast, impulsive behaviors, like buying things one cannot afford, quitting a job without having another one lined up, or driving recklessly, are typically performed because it feels good to engage in the behavior. Similarly, perfectionism is often motivated by a positive sense of accomplishment in doing things optimally. Perseverative behavior, stereotypic behavior, or self-injurious behavior must also be distinguished from compulsions. The most common compulsions are checking, washing, and counting. However, most individuals with obsessive compulsive disorder report multiple types of compulsions. When diagnosing obsessive compulsive disorder, we also specify the amount of insight an individual has and whether or not they have current or past tic disorder. That's because tic disorders often co-occur with obsessive compulsive disorder and run in families with obsessive compulsive disorder. Differential diagnosis can be a challenge with obsessive compulsive disorder. As outlined on prior slides, the key to differentiating is making sure that thoughts and behaviors truly fit the criteria for obsessions and compulsions. Some common differentials include excessive worries as characteristic of generalized anxiety disorder, preoccupation with appearance as evidenced in body dysmorphic disorder, difficulty discarding or parting with possessions, as is the case of hoarding disorder, hair pulling, as in trichotillomania, skin picking, as in excoriation disorder, stereotypies, stereotypic movement disorder, ritualized eating behavior, seen in eating disorders, preoccupation with substances or gambling, as is seen in substance-related and addictive disorders, preoccupation with having an illness, as is the case in illness anxiety disorder, sexual urges or fantasies that characterize paraphilic disorders, impulses that characterize disruptive impulse control and conduct disorders, guilty ruminations that are characteristic in major depressive disorder, thought insertion or delusional preoccupations that may occur in schizophrenia spectrum or other psychotic disorders, and finally, repetitive patterns of behavior that may occur in autism spectrum disorder. Obsessive compulsive disorder usually has its onset in the late teens or early 20s and has a lifetime prevalence of 2 to 3%. If identified, it's important to try to get patients into treatment because without treatment, the course is often chronic and deteriorating. Selective serotonin reuptake inhibitors and clomipramine are effective in the treatment of obsessive compulsive disorder, but typically higher doses than are used for depression are required. Most patients won't get full relief from symptoms with these medications, but are much less impaired and distressed by the symptom reductions they do experience. For patients with treatment-refractory obsessive compulsive disorder, augmentation with other medications or psychosurgery may be necessary to get symptom reduction. Behavior therapy for obsessive compulsive disorder is called exposure ritual, or sometimes response prevention, or ERP. In exposure ritual prevention, an individual is exposed to stimuli that elicit obsessions or urges to perform compulsive acts, and prevented from engaging in the compulsive ritual that would normally reduce distress. This treatment is effective in 70% of individuals who are willing to participate in it, but about 30% of patients will decline this kind of treatment. This kind of treatment is difficult with individuals who only have obsessions or whose compulsions are mental activities like counting, because ritual prevention is difficult to achieve. Behavioral therapy and medication seems like an optimal choice for most patients with obsessive compulsive disorder because up to 25% of patients who try one or the other will fail on the monotherapy. Body dysmorphic disorder is diagnosed when a person is preoccupied with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. And at some point during the course of the disorder, the individual has performed repetitive behaviors, like checking in the mirror, excessive grooming to hide or fix the perceived flaw, or seeking reassurance from others about their appearance, or mental acts, comparing their appearance to that of others in response to these appearance concerns. When diagnosing body dysmorphic disorder, we also need to consider which specifiers apply. There are specifiers for the amount of insight the person has, as was the case with obsessive compulsive disorder. There is also a specifier for a specific type of body dysmorphic disorder called muscle dysmorphia, in which the individual believes they are lacking desired muscle mass or definition. This is often the case even once they have obtained substantial muscle mass and definition, as in the case of a bodybuilder. Body dysmorphic disorder occurs in only about 1 to 3% of people in the U.S. and is equally common in men and women. Individuals with this disorder are unlikely to marry, and if they do marry, are more likely to get divorced. The most common focus of the preoccupation is on the head and face, such as perceiving a small bump on one's nose as a hideous malformation or a small acne scar as a crater. It's a serious disorder because it can lead to repeated unnecessary plastic surgery to correct the perceived defect, and also is associated with social anxiety, depression, suicidal ideation, and attempts. Selective serotonin reuptake inhibitors and cognitive behavioral therapy are common treatments for body dysmorphic disorder. Hoarding disorder is diagnosed when a person has persistent difficulty discarding or parting with possessions, regardless of their actual value, because of a perceived need to save the items and the distress associated with discarding them. The difficulty discarding possession results in the accumulation of possessions that congest and clutter active living areas and substantially compromises their intended use. If living areas are uncluttered, it is only because of the interventions of third parties, for example, family members, cleaners, or the authorities. In hoarding disorder, excessive acquisition is specified if, in addition to not discarding items, the individual also acquires excessive items through shopping, grabbing items from in front of a neighbor's house on trash collection day, or other means. Insight is also specified. There is evidence that selective serotonin reuptake inhibitors may benefit some patients with hoarding disorder, and cognitive behavioral therapy also helps some patients, but has mixed results. In part, this is because success usually requires home visits or hiring a personal organizer to help the individual discard accumulated items, as well as ongoing monitoring to prevent reaccumulation. Trichotillomania, or hair pulling disorder, is diagnosed when an individual recurrently pulls out their hair, resulting in hair loss and an inability to stop doing it despite repeated attempts. Trichotillomania can affect any site where hair grows. Think head, eyebrows, arms, anywhere hair grows. Many patients may have small bald patches but are able to hide them, so a patient with trichotillomania won't readily be identifiable in most cases. Trichotillomania commonly co-occurs with mood and anxiety disorders and seems to respond to selective serotonin reuptake inhibitors or clomipramine. It also seems to respond to a form of behavior therapy called habit reversal. During habit reversal, an individual is taught to notice the urge they experience just before they pull their hair, and then to engage in an incompatible behavior that prevents the hair pulling. Habit reversal is also applied to excoriation disorder and tic disorders. The last disorder we'll talk about in this presentation is excoriation or skin picking disorder. Excoriation or skin picking disorder is diagnosed when a person engages in recurrent skin picking that results in lesions, and the person also cannot stop picking despite trying to do so. This concludes this presentation on obsessive compulsive and related disorders.